Okay, are we ready to go? Good.
Yes.
All right, everyone. Hello, good morning, and welcome to the Research Ethics and Policy series. Thank you to to those of you who are there in the room, and we're glad to have many people joining online. Unfortunately, I am one of those people joining online. I am positive for COVID and just towards the end of my isolation period. So I really regret not being there with you all today. I should introduce myself, of course. I'm Holly Fernandez-Lynch. I'm an assistant professor of medical ethics and health policy, and I am the Research Ethics and Policy series co-chair along with Steve Jaffe. Today, we are thrilled to be welcoming Dr. Greg Gonzalves, who will be presenting on AIDS activism and the quest for access and answers on new drugs. This is a very special day. We have been trying to get Dr. Gonzalves to pen for what feels like ages. It's taken a lot of rescheduling both before and during the pandemic. So no pressure, Greg. I'm sure this will be very much worth the wait. I am just going to say a couple of words by way of introduction and a few announcements. We are recording this session and we will post the video to the Medical Ethics and Health Policy website as soon as it's ready. We plan to continue hosting reps in this hybrid fashion for the foreseeable future. So we encourage you to join us in person if you can, or virtually if you cannot. Next month, you can see on the slide here, we'll be joined by Dr. Alan Flake from CHOP, who will be discussing his pioneering research on artificial wombs. And we will be thinking about the 2023 schedule before long. So please let us know if you have suggestions for folks that you'd like us to consider inviting, especially individuals from diverse backgrounds and who would contribute diverse perspectives to issues relevant to research ethics and policy. I just wanted to give a quick reminder about some online resources from our department. We have a series of short research ethics courses that are available for free continuing education credit. Some of these can also be used to satisfy research ethics training requirements at both Penn and CHOP. And then let me thank our co-sponsors, all of whom help make reps possible. And of course, thank you so much to Mary Pham for her always excellent work to administer this series and make things work so smoothly, especially as we've moved now to this hybrid model. And with that, I am really pleased to introduce today's lecturer, Dr. Greg Gonzalves, who is an associate professor of epidemiology at Yale, where he is also associate professor of law and co-director of both the Global Health Justice Partnership and the Collaboration for Research Integrity and Transparency. He is an expert in policy modeling on infectious disease and substance use, as well as the intersection of public policy and health equity. For more than 30 years, he's worked on HIV/AIDS and other global health issues with several organizations, including ACT UP and the Treatment Action Group, among others. More recently, he's been applying his expertise to policy responses to the COVID pandemic, which has been really appreciated and valuable, as well as sharing what he's learned about access to investigational medicines and engaging with both companies and FDA with new patient groups beyond the HIV community, including patients living with ALS. In 2018, Dr. Gonzalves was named a MacArthur Fellow, and we are just thrilled to have you here today. Please take it away, Greg.
Thanks, Holly, and sad that you can't be here, but we'll have to come back and come for another visit. So you can hear? Good. So this is a policy talk, not a research talk, so there's going to be no slides, and maybe that's a consolation to some. So I'm going to read most of this and then we can talk about what you think about the conclusions as we get to the end of it. So, you know, if you're going to sell a medicine containing alcohol, morphine, opium, or cannabis, you have to put it on the label. You have products including a radium-containing tonic that leads to a slow and painful death, an eyelash dye that has already blinded many women, and an exhaler that falsely promises to cure tuberculosis and other pulmonary diseases linger on the market. Now, 107 people are dead from one drug, a sulfanilamide elixir. This is the world we lived in until 1938. that year, President Franklin Delano Roosevelt signed the Food and Drug and Cosmetic Act into law. But even then, dangerous drugs could only be blocked from the market for 60 days. Many of you know this history. You probably even know that a young research assistant named Frances Oldham Kelsey at the University of Chicago was the scientist that figured out that diethylene glycol was the chemical culprit in these elixir deaths in 1937. You know, some have suggested that the modern Food and Drug Administration was born out of tragedies like these, and tragedies well averted, well, again, by a physician and FDA scientist named Frances Oldham Kelsey, who blocked the release of thalidomide on the American market in the early 1960s, even as the manufacturer, the Merrill Company, maintained in a front-page Washington Post article that half the deformed children were delivered to mothers who probably had not even taken thalidomide, and conclusive proof is laughing for such assumptions that they did. You probably may also know that the thalidomide tragedy led in part to the Kefauver-Harris Amendment to the 1938 Act, which required companies not only to prove the safety of their medicines, but their clinical effectiveness as well. But you may not remember that the American Medical Association balked at the efficacy requirements in the bill, saying the only possible final determination as to the efficacy and ultimate use of a drug is the extensive clinical use of that drug by a large number of the medical profession over a long period of time. You didn't need the 21st Century Cures Act to bring calls for real-world evidence into life, nor wait for groups like ACT UP to cry that the FDA is killing us, because articles appeared over a decade before my comrades in ACT UP and I descended upon Rockville, Maryland, and the FDA's headquarters with statements positing that the FDA efficacy requirements increase the cost of drugs, slash the rate of the introduction of new agents, and deprive the sick and the dying of vital medicines. This was in Reason magazine in 1974, a then new libertarian journal. And while the Pharmaceutical Manufacturers Association did not like the 1962 amendments, they knew they weren't in a position to stop them. Quote, the Pharmaceutical Manufacturers Association decided to agree to the Kefauver bill because, according to the Wall Street Journal reporter, the companies don't think they have any choice. Ruefully, the industry admits it could do little to block the new controls, even if they tried. In the past month or so, our political situation has changed, and we can't get anyone's ear in Washington, lamented one company official, concluded the New York Post. It is almost certain that new drug controls will emerge before Congress adjourns this fall. The reason is simple, thalidomide. Now look, the struggle to obtain proof of efficacy has always been a running battle. Even after the Drug Efficacy Study Implementation Initiative by the FDA to evaluate drugs on the market from the pre-Kefauver era showed that only a third of close to 3,500 drugs evaluated were ineffective. As my colleagues Joe Ross and Ravi Gupta have shown, many manufacturers kept their drugs on the market anyway for decades, leading the FDA to enact the Unapproved Drugs Initiative in 2006, 40 years after the DESI initiative began. So the end game for drug approval in the US, and I'll get to what it was, needed something to start it moving along. It turned out that the match that lit the fire was us, my friends, my colleagues, and my comrades in ACT UP. Daniel Carpenter's masterful political history of the FDA, Reputation and Power, if you haven't read it, you should, ends the story with AIDS and the FDA in 1992, just as the story takes a critical turn. And while he describes some of what I'm about to tell you, most of it hasn't been written up in a scholarly way. So some scene setting. In the midst of another pandemic, which some of you remember, it's hard to understand the fear and terror many of us felt back then. I want to quote old friend and colleague Vito Russo, the late film historian who described the AIDS epidemic in the 1980s. He said, living with AIDS is like living through a war in which is happening only for those people who happen to be in the trenches. Every time a shell explodes, you look around and you discover that you've lost more of your friends, but nobody else notices. It isn't happening to them. They're walking the streets as though they weren't living through some sort of a nightmare, and only you can hear the screams of the people who are dying and their cries for help. Nobody else seems to be noticing. So AL-721, an egg leopard concoction people made in their bathtubs, dextran sulfate, N-acetylcysteine, compound Q, a Chinese cucumber extract, isoprenazine, peptide T, an inhaled medication, that I once sneaked into a St. Vincent's Hospital room in New York City to spray up the nose of our friend Jerry Johns, who was dying of PML at the time. There were dozens and dozens of drugs that we invested our hope in, And these were cataloged by the American Foundation for AIDS Research, AMFAR in their experimental treatment directory. And the People with AIDS group sold on the black market after traveling all over the world to bring them back to New York City. As my former colleague Derek Link says in the film How to Survive a Plague, while giving us a tour of the stockroom of the PWA Health Group, here are our lovely medications. He breaks out in a smile and a nervous laugh and says, and none of them work. This was the context in which ACT UP descended on Rockville to seize the FDA in 1988 with the following demands: shorten the drug approval process, no more double-blind placebo trials, include people from all affected populations at all stages of HIV infection in clinical trials. Medicaid and private health insurance must pay for experimental drugs, and the SBA must support rather than harass community groups working to keep community members alive. I abbreviated some of the context of the demands that day, but you may hear echoes of them in some of the current debates. And it's not a coincidence. All that fear and terror we felt back then got baked into how we thought about drug approval and regulation. We had no time to lose. And if some of this was Russian roulette, so be it, we'd take the gamble. Other demands we had made sense, particularly about diversity in clinical trials, about establishing massive expanded access programs that parallel track, another demand at the time, which allowed DDI and D4T, two nucleoside analogs, to be tried by tens of thousands of people ineligible for clinical trials before the drugs were approved. But what is left out of this story is what came next. AIDS activists succeeded in getting the FDA to institute an accelerated approval mechanisms for AIDS drugs, which came online in 1992. As we all know, it allowed an approval of the drug based on effects on surrogate markers reasonably likely to confer clinical benefit, with the requirement that companies followed up with confirmatory studies to show this to be the case, that the drug indeed extends survival or at least delays disease progression. But even as accelerated approval was being born, our doubts continued to grow. The first generation of AIDS drugs, the nucleoside analogs, AZT and its cousins, were hardly the blockbusters we saw emerge only a few years later with the introduction of protease inhibitors and used in combination with these early agents. In fact, the study data that was emerging at the time was contradictory. For instance, 3 American studies on AZT's effects suggested that the drug could delay disease progression and extend survival. But the large 1993 Anglo-French Concord study, placebo-controlled by the way, suggested that even if CD4 counts rose, there was no benefit to early AZT. It was the talk of the 1993 International AIDS Conference. Even before Concord, the plausibility of small rises in CD4 cell counts with drugs like DDI and DDC was dubiously regarded. When DDC, the first drug to receive accelerated approval, came back around to the FDA in 1983 in the fall following the AIDS conference in Berlin that summer for interrogation of its confirmatory trials, we were there to argue for the drug's withdrawal from the market, along with the advisory committee that said the same. I was dramatic as a 30-something-year-old in my testimony to the committee that day and said, "We have arrived in hell," Greg Gonzalves of the Treatment Action Group told the committee. AIDS activists and government regulators have worked together with the best of intentions over the years to speed access to drugs. What we have done, however, is to unleash drugs with well-documented toxicities on the market without obtaining rigorous data on their clinical effects. Once a drug is fully approved, there's no way to compel the company to do more trials. In 1994, I was a voting member of the FDA's Antiviral Drugs Advisory Committee. The FDA had started putting community members, who are not physicians, not public health experts, on the committees. And I did the unthinkable. I voted against the accelerated approval of D4T, suggesting that the proposed confirmatory trials were too small to show a treatment effect. I was outvoted by the clinicians on the panel, but not before the advisory committee chair, Debbie Cotton, asked David Feigl, who was the director of the FDA's antiviral drug division, apropos of the basis of the accelerated approval decision, "Is evidence required?" Debbie asked. "No," David Feigl said. "Is evidence allowed?" Debbie Cotton continued. "Yes," replied Feigl. To be in that room when that sort of bizarre series of statements happened at the end of the hearing was something that I'll always remember. So I'll maintain this was the beginning of the end game, the gradual dismantling of the Kefauver amendments for Kefauver amendments requirements for proof of clinical efficacy, and it was a death by 1,000 cuts. AIDS activists opened the Pandora's box for industry, its allies, and the deregulatory right which from the FDA to the EPA was only interested in tearing it all down. While AIDS activists started the ball rolling with our push for accelerated approval, we couldn't stop it. Industry had found a willing partner in the decades-long campaign to weaken the FDA's regulatory authority, patients themselves. And once protease inhibitors came online in 1996, we largely abandoned our struggles with the agency. We had drugs that had dramatic clinical benefits. Approval for us was no longer contested in the same way after 1996. And while there were a few activists and patient groups, most notably Fran Visco and the National Breast Cancer Coalition, whom we all met back then and who is still with us today, who held the line on the need for evidence beyond surrogate markers and still do today, most patient groups parrot our unreconstructed demands from 1988. And Big Pharma knows this. Since the rise of ACT UP, pharmaceutical companies have propped up patient groups to do their dirty work. According to Kaiser Health News back a few years ago, in 2015, drug companies gave at least $116 million to patient advocacy groups in a single year, and 12,000 donations from large publicly traded drug makers to such organizations. Quote from Kaiser, unlike payments to doctors and lobbying expenses, companies do not have to report payments to groups, and these donations dwarf the total amount the company spent on federal lobbying. The 14 companies that contributed $116 million to patient advocacy groups reported only about $63 million in lobbying that same year. To continue, a 2017 JAMA study concluded that 67% of a national sample of patient advocacy organizations reported receiving funding for-profit companies. 12% received more than half of their funding from industry, a median proportion of 45% of industry funding was derived from the pharmaceutical, device, or biotechnology sectors. So the irony of this moment is not lost on me. In 2015, when former FDA Commissioner David Kessler and my old colleague Mark Harrington from the Treatment Action Group and I wrote an op-ed for the New York Times opposing the 21st Century Cures Act, one of the pieces of legislation that pops up every few years to further erode the authority of the FDA. Importantly, almost every disease group, every member of Congress was unanimously in support of the bill. But what Mark, David Kessler, and I wrote was, the 21st Century Cures Act could substantially lower the standard for approval of many medical products, potentially placing patients at unnecessary risk of injury and or death. While the legislation does not mandate this approach, it opens the door to it. For instance, the current version of the bill would allow consideration of drug approvals based on clinical experience. Remember the AMA in 1963 around the Confirmatory amendments and what they said about real-world evidence. Other provisions could mandate the use of biomarkers to approve a wider variety of drugs for far beyond those for just serious and life-threatening illnesses. Approval standards for medical devices, already lower than that for drugs, could become even less rigorous, allowing life-saving devices like heart valves and stents to be revamped by manufacturers without the FDA even reviewing changes. Through the agency would have to be just notified. Only a set of initial studies could be required for desperately needed new antibiotics. Worse, the critical final studies that show that new drugs could save lives could be made optional. The overuse of antibiotics has led to an epidemic of drug-resistant bacteria. The bill would give incentives to hospitals to prescribe these new antibiotics, encouraging more widespread use. Well, the 21st Century Cures Act is now law of the land, and a Cures Act 2.0 is on its way, and the same forces are marshaling themselves against Representative Frank Pallone's Accelerated Approval Integrity Act, which among other things would do things like require manufacturers to enter into an agreement with the FDA on how studies will be conducted before the agency can grant accelerated approval, which may include details like enrollment targets, milestones, and study designs. Require more frequent updates on post-approval studies, including updates on enrollment targets, milestones, and study design. Outline expedited procedures for withdrawing approval. Automatically revoke accelerated approval status 1 year after post-approval studies are scheduled to be completed, and in no case later than 5 years after approval. I'm not sure how anybody can think any of these provisions are unreasonable. It closes the loop on accelerated approval in that it still provides early access to drugs, but it ensures that the gathering of evidence on clinical effects, their benefits, are done in a timely manner. What's not to like? Well, what is the end game for industry? What is the end game for the pharmaceutical companies around the US and around the world? Well, in the mid-1990s, many of us worked on opposing the Dietary Supplement Health and Education Act, or what we called the Snake Oil Protection Act of 1994. The bill, of course, deregulated the supplement industry and gave the barrage of TV commercials we see today touting the benefits of things like jellyfish extract or mental acuity and memory, all perfectly legal, as long as you say the claims haven't been evaluated by the FDA faster than the caller in the final round of an antiques auction, or in type small enough that you need a magnifying glass to read it. So you might want to maintain that this kind of baseless marketing could never happen in the context of real medicines. But just look back to the DESI initiative and the fully 1/3 of the drugs that proved ineffective after subsequent review. We can even look at Aduhelm, which I think you've heard of in the context of this policy series over the course of the past few weeks. A drug that the entire advisory committee rejected, had little evidence to support its use, has demonstrated toxicities that are dangerous to patients, and it's being touted as a treatment for Alzheimer's disease and has its manufacturer, allied with the Alzheimer's Association, whose CEO makes close to $2 million a year, pushing for its approval and now reimbursement by CMS. And you can also look at Exondys 51 or Addy, two other dubious approvals by the FDA over the past few years to further extend examples of drugs with not much benefit, that have clinical benefit, with not much more support for their effects than some of the supplements you see on the nightly cable news. And even drugs that have benefits for some clinical indications linger on the market without proof of benefit for others. As research by Joe Ross, Aaron Kesselheim, Josh Wallach, and others have demonstrated, we can make the case that we know less and less of the medicines we put in our bodies as we pay more and more for them nowadays, with many agents going through expedited pathways, but confirmatory studies often a day late and $1 short. Delayed in execution and completion, often with methodological challenges in design or in sample size. There are opportunity costs for patients, and all of us, when we don't follow through and demand the data we need to make decisions about the drugs we put in our bodies, the ones we pay for, the ones we invest our hopes in. So the end game for industry, what is it? The end game for industry is regulatory capture. This isn't outright corruption, no money needs to pass hands, but is it a climate in which the FDA and industry views harmonize nonetheless, in which industry's aspirations become the agency's own? And regulatory capture is well on its way. Don't get me wrong, there's some great people at the agency committed to public health and ensuring drugs are safe and effective. We do have our modern day Francis Oldham Kelseys, but they are often sidelined and dismissed. I sent this draft of this talk to some friends who recently left the FDA, and they said, people are leaving in droves. The FDA has figured out a way to keep people silent and silence dissent. So we can talk about people like David Graham, who warned senior FDA officials about the risk of heart attacks and sudden death with higher dose Vioxx, who, according to his own sworn testimony in Congress, was not allowed to present the data at a scientific conference in 2004 unless he modified his conclusions. Unless you take this as an exception to the rule at the agency, particularly at CEDAR, the Center for Drug Evaluation and Research, let's hear the tale of Avandia from Steve Nissen, the chair of cardiovascular medicine at the Cleveland Clinic. Steve says, in 2005 and 2006, GlaxoSmithKline secretly conducted an analysis of the cardiovascular safety of Avandia and concluded that the drug increased the risk of heart attacks and related events by 30%. This observation had grave implications. 2/3 of diabetics, the intended recipients of the drug, eventually die of cardiovascular complications. Initially, GSK withheld the internal analysis from the FDA, but in 2006, the company informed CEDAR of the findings. FDA statistician confirms the risk, but incredibly, CEDAR and GSK agreed privately to conceal this hazard from patients and practitioners. Now, the saga of Billy Dunn and Patricia Cavazzoni and Janet Woodcock and Aduhelm makes a whole lot more sense when you start to put that story into the context of the examples in which the FDA sided with the industry defending the indefensible. This is the last story I promise. It's the tale of Sarepta, where the FDA's acting chief, Luciana Borio, said, granting accelerated approval here on the basis of the data submitted could make matters worse for patients with no existing meaningful therapies, but by discouraging others from developing effective therapies for DMD, and by encouraging other developers to seek approvals for serious conditions before they have invested the time and research necessary to establish whether a product is likely to confer clinical benefits. The director of the Office of Drug Regulation at FDA, Ellis Unger, continued, by allowing the marketing of an ineffective drug essentially a scientifically elegant placebo, thousands of patients and their families would be given false hope in exchange for hardship and risk. I argued that this would be unethical and counterproductive. There also could be significant and unjustified financial cost, if not to patients, to society. But Janet Woodcock overruled, arguing that Sarepta needed to be capitalized, quote unquote, essentially saying that if the drug wasn't approved, the company wouldn't have enough money to continue studying the drug and similar drugs in the pipeline. And the approval would jack up the company's share price, giving more money to continue research. The final decision went to then Commissioner of the agency, Rob Califf, who sided with Janet Woodcock. So regulatory capture represents a distortion in which an industry meant to be the subject of regulation and scrutiny for the good of the American public finds a way to elevate its influence over decision-making at an agency for its own benefit. That is to say, the fox guards the henhouse by proxy. And while I've raised issues with particular staff at the FDA, it would be a mistake to think that I'm talking about bad apples or good people making poor decisions. The FDA has been under relentless pressure from the regulatory right for at least 30 years, with legislation meant to weaken its authority popping up at least every once a decade. What is the 21st Century Cures Act or the Food and Drug Administration Act in the 1990s? Every 10 years or so, we get a piece of legislation which begins to whittle away at FDA's essential features. But even legislation meant to be a gift to the agency, like the Prescription Drug Users Fee Act, which mainlines millions of dollars into the agency's budget, was a Trojan horse, as it contained two poison pill provisions. One, fees could only be used for new drug reviews, and only if FDA continued to allocate at least as much money from congressional appropriations to new drugs that it had the year before the law was passed. With an agency chronically underfunded, this tilted and tilts agency priorities towards more, faster, rather than investment in drug safety, post-marketing enforcement, and discourages scrutiny that may slow down approvals, which are the metric by which the agency is held to account by industry and patient groups, eager for revenue and access, willing to forgo evidence in the short term, and sometimes longer than that. It is no wonder then that the agency is in this way of a very bad case of Stockholm syndrome, in which some of the staff identify with the agency's regulatory captors. While kidnapped heiress Patty Hearst robbed banks in the 1970s, with her own captors in the Sudanese Liberation Army, FDA, along with the drug industry, has ransacked the public trust, imperiling patients and, yes, stealing from both our wallets and the public purse with money flowing to industry from drugs with dubious or no clinical benefits. In January of last year, Daniel Carpenter and I wrote a piece for Stat News begging the Biden administration to appoint a leader at FDA committed to the public health, scientific rigor, and procedural integrity. In the midst of a pandemic, this was more important and is more important than ever. But more importantly, having a leader with scientific integrity, procedural integrity, and committed to the public health is incredibly important, because having a weak FDA serves no one. As we said back then, a loss of confidence in the FDA leads to treatments that are not deemed credible or reliable by patients, clinicians, and payers. And that means billions of dollars lost to the biopharmaceutical industry and biopharmaceutical companies themselves. As we talked to people in early 2021 about chances for change at the FDA, several people told us that the drug industry thinks the FDA pick is theirs, right? Not in any explicit way, but that a reformer was not in the cards. One of the last FDA commissioners, Scott Gottlieb, went from the American Enterprise Institute to FDA to Pfizer's board of directors, where the FDA gig was sandwiched between a right-leaning deregulatory policy shop and one of the largest drug companies in the world. But many of us were relieved by that appointment, because we thought it could have been far, far worse under President Trump. But with President Biden, we were hoping for a new vision for the FDA, a fresh start. But we got more of the same with the appointment of Rob Califf, with strong ties to the industry, and he may be as good as it gets. But a small part of me has to wonder if we aren't suffering from our own case of Stockholm syndrome, thinking that the constraints on our future are limited by those who hold power over us, and that we might as well just give in. Thanks.
Greg, thanks so much for that talk. Mary, can you hear me okay?
Yes, we can hear you.
Okay, great. So I will get us kicked off with some questions, Greg, and then for folks online, if you have questions, please type them in the chat and I will pass them along to Greg. And Mary and Greg, please feel free to call on anybody in the room. I won't be able to see folks that way. Greg, let me start by asking you to opine a bit on how FDA should account for patient perspectives in its decision making, right? So something that Congress has explicitly encouraged and demanded FDA to do more frequently, and maybe we can disambiguate patient perspectives from the perspectives of patient advocacy groups.
So, it'd be disingenuous for me to say that patient voices don't need to be heard at the FDA, because we pushed for it for much of my adult lifetime. But we also have to deal with the fact that I described in this talk today, that many patient advocacy groups are essentially large corporations, which are very sort of remotely tied to the people they tend to serve. You see that largely in the ACTIVISM discussion, where again, the top leadership of the Alzheimer's Association makes more than many people probably at this medical school, right? If you added it all up in their yearly compensation. It's also, when we went into the FDA, when we went into the NIH and some advisory committees, our frame of reference is the public health, and the people we learned from our mentors were many people in medical schools, statisticians, people who work on health policy, because we had an idea that we needed something that was just as precious as access to new drugs, that we needed answers about them. But the mantra of the drug companies, the think tanks that have funded many of these patient groups, has really sort of twisted the debate. So you had the right to try laws, right? Right now, the barrier to expanded access programs in the United States is not the FDA, which approves many expanded access requests within 48 hours, right? It's the pharmaceutical industry that says, we won't do what Bristol Myers did back in 1991, 1992, 1993, in putting tens of thousands of people on DDI and D4T, right? So they twist the language of access, and they've hijacked their message that it is absolutely pervasive, that the only way to get access to a new drug is to put it on the market before it's properly clinically evaluated, because there's no way to get it through parallel track anymore through expanded access programs. I had these long conversations with my colleagues in the ALS field who are caught between these hard decisions about drugs that they think may have some effect, but there's no chance for them to get access to this through an expanded access program. Biogen is a clear case in point. Refused after appeal after appeal after appeal to put out a drug on expanded access. It really wants to push patients to the FDA to use them as a wedge to open up the door to early approval without access to the clinical information that we need to make decisions about our health. So I do think patients need to be part of the advisory committee process, not just at FDA, but at NIH and other federal agencies. But it's not just there to provide sort of raw experience. It has to be done in some way that is responsible to the generation that comes after us, right? Otherwise, we'd still be mixing up AL721 in our bathtubs, selling things to the PWA health group that didn't work, and not learning from our mistakes. It was only a few years after the early initiation of early approvals of drugs that we realized we had drugs on the market that we didn't know if they helped us stay alive, extended our health, or better than nothing, right? And I don't think that, I think that whole idea is lost on patient groups right now, even patient groups that really have no other choice. They assume any drug is better than no drug, and a new drug must be better than an old drug.
I will ceiling mics. Oh, yeah. I was just letting folks know there are ceiling mics. So if you have any questions, just raise your hand or speak. What's that, Holly?
I was going to say I can keep asking questions. I can't see the folks in the room. So if there's, oh, here's a question in the chat. Greg, this question is from Sharon Moon. And she asks, can you speak to incentives for MDs and hospitals to go along with this? Does their income or revenue rise with new drugs, new medical devices? And she's asking about conflicts with professional organizations like the American Medical Association.
So this, to the MDs online and in the room, I'd push this back to you because I don't know about how the instructors in hospitals and in medical practices work. What was clear in the ACTIVISM situation is that physicians, by and large, did the right thing, but there's a whole set of physicians who are arguing with the Alzheimer's Association for CMS to reimburse this drug, costing taxpayers lots of money. But I don't understand what the built-in incentives are for delivering drugs that don't work in the context of the medical setting. If you have ideas about from your own sort of experience, it'd be interesting to know because I don't follow the sort of medical side of this itself, the clinical side. That
yeah, at a place like, curious what you think too, but at a place like Penn, I think there's less incentive for that. I mean, there's just less presence of pharmaceutical manufacturers. That may be an internal medicine specific thing, but honestly, like there's only downside to prescribing therapies that don't work for us. Yeah.
It seems like there's quite a bit of leverage at the payer level, you know, like specifically with regards to adverse tiering of different medications, you know, certain medications being higher on a formulary versus lower on a formulary, and whether a specific insurer chooses to do that or whether it's CMS who chooses to do that. It seems like that seems to be a bit of a stronger guiding force.
Maybe out in a more community setting, there may be an influence of infusion fees. So there are reimbursed fees for infusion services.
yeah, and then you get, you know, Vinay Prasad, before he went off the deep end on COVID, wrote some interesting stuff about the clinical evidence on many oncological medicines. That, you know, outside of surrogates, there's not a lot of data on long-term clinical benefits. That baffles me, like why cancer doctors would have an incentive to continually prescribe drugs that have dubious clinical benefit and mostly being prescribed off-label. Well, I don't understand why that happens, why you just sort of throw the kitchen sink and think that's appropriate medical therapy. But I am not an oncologist. Maybe there's some vast, you know, rationale for this. But, you know, the way Vinay Prasad and others describe sort of the crisis in cancer therapeutics in terms of evidence seems pretty dire in terms of like the clinical situation. I was at a meeting of health technology assessment bodies in Europe pre-pandemic, and one of the heads of the German version of the AMA was on a panel with me saying, we really don't know what to do. We don't have, doing cost effectiveness of trying to understand what they do is very difficult if you don't have the information from clinical trials to establish their clinical benefit. So I think there's a little bit of a Wild West notion about what's happening in the clinical space rather than sort of outright sort of collusion or disciplinary capture.
Greg, I wanted, oh, go ahead.
Please go ahead.
I was going to invite you to say a bit more about the relationship between FDA approval and payment decisions, and the fact that they obviously are not linked directly now, whether you think they ought to be or what the solutions ought to be going forward.
Well, it's pretty easy for me. I think we need a health technology assessment body in the US to sort of evaluate new medicines in terms of their suitability for approval. We pay for everything here, right? And we have no ability to set prices. So we just pay more and more for drugs we know less and less about, right? And so it doesn't seem a rational way to run a health system or to prescribe drugs or to reimburse them. What's happening right now about ADUHELM is pretty critical to what the future is going to be like, because basically the Alzheimer's Association and Biogen have unleashed hordes of sort of AstroTurf groups to pressure CMS to rescind its coverage with evidence preliminary guidance, right? And so, if ADUHELM gets approved for payment through CMS, first of all, it's going to be a huge sort of burden on the public purse, but it's also a signal to drug companies in that space and in the pharmaceutical space more generally that, it creates a race to the bottom, which I don't think any of us can afford it in many different senses.
stepping back, I wonder what your thoughts are on the balance between well-designed clinical studies to prove efficacy versus expanded compassionate use access. And is there a tension between those in compromising the ability to actually demonstrate efficacy?
So a couple of things. One is the old parallel track was based on the inclusion was that you couldn't get access to clinical trials. So you were geographically too far away from it. So like you could get DDI through your local physician. So I think expanded access is a great way to take the pressure off the FDA and to provide access to drugs with patients with no other options, right? And that's what it was back in the early days of HIV. We also pushed for better clinical trials, better design, with the help of people like Susan Ellenberg and others who sort of tutored us back in the day, because we knew the answers were important. I think one of the interesting things that's happening now is that, you know, there's this whole discussion of real world data. And I think there's an opportunity to learn from observational studies, not from patient registries, but really using sort of the modern tools, of some of which Athene uses around target trials and causal inference to supplement randomized control trials. But real world evidence alone through patient registries, the EHR is not going to help us. So I do think we need better expanded access programs. I think it needs to be integrated into the development plans by pharmaceutical companies, that they know they have to be able to provide a certain amount of drug, both for clinical trials that they're doing and also expanded access. And often the small companies say we can't afford it. But of course they can afford it if their investors know it's part of the critical path to getting a drug approved. Otherwise, you basically create this enormous bottleneck pressure to get things to the FDA because it's the only way to get access to them early before trials are finished.
Greg, can you comment a little bit more on this, on the use of expanded access and the kinds of claims that companies might make to refuse to provide it? So maybe for folks who haven't followed it as closely, you could talk a little bit about Biogen and the Lisa Stockman-Moriello example, and claims and questions about fairness to people who are in a trial versus those who are seeking expanded access.
Well, the whole idea that Biogen couldn't afford to give Lisa or ALS patients access to that drug was ludicrous. Just the amount of money they spent on the Aduhelm PR campaign, you know, could have allowed for the manufacture of lots of doses to give access to people in that case. The main thing, and I think what happened with Sarepta, is that you didn't have a very large patient population that needed that drug. And they explicitly told patient groups that you're not going to get it through expanded access. We can't afford to do it. And really put enormous pressure on patients, their families, to beg the FDA to move it to the agency quickly, even though, you know, they were in the same room and they saw the same data, they heard the same claims. Their desperation was capitalized on the same way in which I would say drug companies capitalized on our fear and desperation, you know, back in the late 80s. But, you know, the policy landscape is far less flexible right now to open up a parallel track or an expanded access program or think of other ways to deal with early access than it was, you know, 30, 40 years ago.
I have another online question Holly will read out loud. Two more.
Yes, great. So the first is from Lynette Martins, who asks, Greg, what are your thoughts regarding patients with rare diseases? Are there lessons from the AIDS advocacy groups that can be gleaned and applied for their benefit?
So it's interesting. ALS I don't consider rare, but I've had the privilege of working with people living with ALS for the past 2 years during the pandemic. And what's interesting to me is that there's enormous pressure focused on the FDA. The problem with ALS is not the speed of drug approval, it's the fact that the pipeline is empty, right? And so last October, we set up a meeting with Dr. Walter Koroshetz, who's the director of NINS, with a group of people living with ALS and their advocates to say, let's talk about the design of natural history studies, setting up a real clinical trials network for ALS, a whole set of research agendas around ALS research from basic to clinical to natural history, which actually mirrored what we did in the late 80s, early 90s, because we realized, crap, there's not 100 drugs in the FDA's pipeline that they're just sort of keeping from us. There's just not enough coming through the pipeline to save our lives. And this is, I think, the case that some ALS activists are making now, that NIH is where the action is, right? They spend maybe, I think when we looked at the list of grants, it's about maybe a little over $100 million. But it's not clear that that money is being spent wisely, that there's not redundancy or gaps in the NIH's ALS research effort. Sharon Begley, she's a health journalist who just did an investigation of the basic science studies in ALS, in which even the mice studies are underpowered in terms of the number of mice that they put into these experiments. And so there's a whole area of activism that we took upon ourselves around clinical and basic science that was really, really important, doesn't really get discussed. But the FDA is like the end of the pipeline. It's the last of your worries. If there's nothing coming in the door, there's nothing to go out the other door at the other side. And so that's the rare disease stuff for me. It's like, it's not that the FDA is killing you, it's that there's nothing in the pipeline that's going to be helpful to you. And the real action is at NIH. And often they, it's interesting to see Walter Koroshetz, after a history of AIDS activism for 40 years, really being baffled by the idea that people living with ALS had a right to have a seat at the table, to have discussions about how they did clinical trials, natural history studies, basic research. I think they're coming around, but it was clear that like that culture shift sort of evaporated with HIV, and will die with Tony Fauci.
Are there any other questions in the room before we go to one more in the chat? Oh, yep, a theme.
So I find this whole idea of regulatory capture like so fascinating. I'm curious, I'm just thinking beyond the FDA. I know that your talk was about the FDA. Are you seeing evidence of that in other agencies as well? Because I think it's been going on since the 60s. I was reading Benjamin Applebaum's book about the false prophets, about economists and how they've kind of been doing this for quite some time. So I'm curious if you're seeing this in other health agencies as well, the same type of capture.
Well, it's funny. So I wrote this talk a few days ago and I sent it around to people, and they said I was not harsh enough. They're basically, regulatory capture at the FDA is not sort of like slowly advancing. It's basically, it's already happened, and that there's very, very little that we can do. And that people, all the sort of horror stories you hear from Vioxx to Avandia to Sarepta to Aduhelm are really sort of the state of the agency now. Of course, there's some great people there, but in general, industry rules the roost. The other place where a lot of this is happening is the EPA, right? Wherever you have like industries being regulated that are incredibly powerful, you see this happening. And so I don't know sort of administrative law and regulatory policy well enough in these other industries, but it's clear that under the the whole EPA regulation about during the Trump administration about you had to be open about it's under the guise of research transparency, but it's really going to really weaken the agency's ability to build regulations. It's clear that this is the path, and this is it's interesting that the think tanks that are interested in FDA deregulation are the same ones interested in EPA and other federal agencies, where there's large monies involved and a regulator. They're looking for avenues to weaken it. I mean, the sad story is that I feel particularly guilty that we helped sort of open up the door for deregulation at the FDA. You might say might have happened anyway, but we provided a template for it, which something I will have to live down for the rest of my life, basically.
So Greg, we have another question from Sharon, who asks, how do you bring together patients? How can you bring them together on these questions? We tend to organize by disease, where we see each other as vying for the same piece of pie, and that opens the door for groups being picked off. A policy can be made, for example, an insulin copay cap that satisfies one group but leaves the problem for everyone else. Any advice about how to encourage more all for one, one for all?
Well, on the bad side, for 21st century cures, every disease group basically piled on and supported that bill unwisely. And I think we need to talk about conflict of interest and scrutinize some of the large disease groups. I think they're huge corporations now, and I'm not quite sure how grassroots they are. I'm working with people living with ALS. I've worked with some folks with T1 International who've done a lot of insulin pricing. It's very hard to bring groups together. The one interesting example of it, which happened during the time that I talked about in my talk, is Christopher Reeve. During the disease wars of the 1990s, when I was like, not proud, but we went to Rockefeller University to protest the head of the American Heart Association, who's a cardiologist there. We went to meet with Morton Kondracki, who is on the board of the Parkinson's Disease Foundation, because he was saying basically take the AIDS budget, parcel it out, and give it to other diseases. And we were not going to have that happen to us. And so there's a lot of fighting going on between disease groups in the 1990s. And we were all on Capitol Hill one day, and Christopher Reeve came in his wheelchair, and he basically said, stop, you're not going to do this. What we're going to do is we're going to work together to build consensus around doubling the NIH budget. We're like, ha, 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 that'll never happen. Of course, it happened, right? It was one moment in time in history where the disease groups got together on a common cause. And yes, the issues around how much AIDS research gets funded compared to other diseases was still on the table, but we were able to put that aside for that one moment to push for the doubling of the NIH budget. And it happened, I think, because you were able to sort of put parochial interests aside for that one moment. With FDA, I don't know if that's possible. I mean, what we really need is a publicly funded agency run by a public health scientist. But right now, PDUFA funds it, and you often have somebody who's allied with industry come in to lead it. And so it sets up a situation which is really anathema to the public health.
One more question in the chat, right, Holly?
Yes, I actually have a couple. So one coming in from Sophia Bessias, who says, thank you. If you're interested in discussing, I'd love to know, what do you think are the lessons for those advocating for vaccine access for young children? How do or should issues differ for regulation of prophylactics, preventive drugs versus those that are being used for treatment?
I haven't thought about it that much, but one of the biggest fears last year was that the FDA was going to get yoked into like a October surprise during the a year and a half ago, into an October surprise, and they were going to run roughshod off over sort of what they needed to do about evaluating the evidence to approve the vaccines. They didn't do it, and to give credit to Stephen Hahn, who I'm not a big fan of, he was able to hold the line and let that happen. The weird thing with the Biden administration is that on Saturday, I got my second booster. Why? Because I felt like it. Was there evidence? No. But like now you can get a second booster for a vaccine because you feel like it, right? So I thought this sort of interference in scientific decision-making was only something that was happening in the Trump administration regarding the FDA, but it's pretty clear there's been enormous pressure on both CDC and FDA around vaccines to sort of do the White House's bidding. And it's been unfortunate because it starts to erode trust in the public in both public health, but also the federal agencies that are supposed to be trusted to sort of guide us on these issues. So I don't know. I think FERPAC and these other bodies have been pretty good, but a lot of times they've been sidelined over the past 2 years, to our own peril, really.
So I have a related question. Oh, did you have one in the room, Mary?
No.
Okay. A related question from Emily Largent about the COVID pandemic, highlighting many of these challenges about speed and desperation and efficacy, along with bringing greater public attention to FDA. And she asks if you are interested in saying more about your opinion about how FDA has done during the pandemic, which you've just alluded to a bit, as well as what we might think are the longer term effects of politicization of the pandemic. And I'll tag on to that, which is this question of seeing emergency use authorizations get used, right? This idea that, well, maybe in a crisis we don't need as much evidence. How should other patient groups outside the pandemic view that, right? Isn't my disease also an emergency? Shouldn't we lower the standards for approval in my disease area?
Look, 2 words for you: convalescent plasma. I mean, that whole debacle was just a sad day for the FDA, but we're already on a race to the bottom, right? Like the expedited approval mechanisms, what's going to happen with Cures 2.0, the EUA situation adds insult to injury, but it's not surprising in the context of where the agency's been going for over 10 years. And so I assume that give us a couple of years, the EUA is going to become a new mechanism to push for expanded access, early use of drugs that, again, have limited clinical evidence for their effectiveness. And so in the context of the pandemic, you could make a case that it was a wise thing to do, but then you had convalescent plasma, in which you really saw an agency capitulate to what the White House wanted them to do. And it was, again, just another black mark in the agency's reputation. But, at this point, it's not quite sure we can do anything to rescue the agency and return it to sort of a protector of the public health.
Okay, Greg, I will ask one closing question, which is, if you were sitting next to Rob Califf, right, who's just taken over the helm of FDA again, what would your most important message be for him?
Well, Frank Pallone's bill on accelerated approval needs to pass. It just needs to pass. It is not getting rid of accelerated approval. It's putting provisions in the law to make sure that confirmatory trials get done in a reliable and expeditious fashion, and offers a tool to the FDA to compel companies to do what they're supposed to do under the bargain in accelerated approval from the first place. So he should get up and stand up for it. Disease groups, patient groups, all these think tanks I talked about are lining up against the bill. And this is a chance, this is a piece of legislation in a Democratic Congress that could make a huge difference to giving some integrity back to the process. And he should step up and say he supports it unequivocally, and that industry, patient groups, everybody else should get behind it. That'd be my number one thing to say to Rob Califf. When Health Freeze is over, he will do that. So.
All right. Well, thank you so much for a great lecture and in this fabulous dialogue back and forth. Really appreciate it, Greg. And I hope everyone in the room and online will join me in thanking Greg. Okay, we will see you all next month.
It's great, really interesting.